Thank you very much for the invitation to talk at this symposium. I'm going to be talking about the uterus and EC coupling and finishing with how we may be able to translate some of this scientific study into helping women in labour. So to begin, sadly, each day around 800 women will die due to complications of pregnancy and childbirth. Thus, understanding myometrial EC coupling is really crucial if we're going to have any effect on developing treatments for these conditions. So I will focus on EC coupling and contraction and divide the talk into three parts. And let's start with an introduction to EC coupling in the myometrium. And there's my little cartoon for EC coupling. So if I may, I'd like to remind you of the fact that the myometrium is a really powerful tissue. I think we're taught about smooth muscle as if it's a weakling muscle with tiny cells. Looking at the myometrium, you'll see hugely long cells in the pregnant myometrium, very robust inward currents, and also a very nice cytoplasmic reticulum, and there you can see the calcium within it. So in the myometrium, we need L-type calcium channels to be opened by depolarization. That is the key to contraction. So if we voltage clamp and give a depolarizing step, what you can see that does is produce inward calcium current, leads to this rise of calcium within the myocyte. If we block L-type calcium channels with nifedipine and repeat that protocol, you can see now no inward current and no rise of intracellular calcium. So clearly we need L-type calcium entry. What we don't need is actually release of calcium from that SR. Simultaneous measurements of SR calcium and cytosolic calcium show quite clearly we can have these calcium transients. The myometrium is myogenic. So here we're seeing the rises of calcium, but no change in the level of calcium within the SR. So that L-type calcium channel entry of calcium is necessary and sufficient for contraction. And it wasn't that I'd saturated the indicator. If you depolarize, for example, then what you see is a much greater increase of calcium and an increase in the SR load. Now we know that the SR containing calcium in some muscles can produce calcium sparks. You can see these local releases of calcium via ryanodine receptors on the SR, crucial for many elements of muscle contraction, but not in the myometrium. To be clear, those calcium spikes were recorded were in the ureter. And I have to say, there are no calcium sparks in the myometrium, so no calcium-induced calcium release, despite ryanodine receptors, no spontaneous inward currents, despite having calcium-activated potassium channels. But what we do have is store-operated calcium entry. As the SR depletes, calcium enters and we get depolarization. So it is its own specific tissue. So for EC coupling, and you're looking there at a sheet of myometrial cells confocally loaded with fluoro4, you can see calcium transients, and we've changed the number of transients by changing action potential stimulation. And you can see that clear relationship there. And of course, those changes in calcium are what give us alterations in muscle force, in this case, within the myometrium. And indeed, uterine stimulants can work by changing excitability and working through this pathway. However, what I'm going to show you in the next part of the talk is that this uterine environment can change that excitability, and it can affect how well stimulants can work or not. And to remind us, here's our EC coupling cartoon. So I want to talk now about the micro and the macro environments and EC coupling. And I want to focus on, briefly, obesity, cholesterol, and caveoli. So caveoli are signaling hubs, these invaginations of the surface membrane, and they're rich in cholesterol. If we decrease cholesterol, which we can do particularly using MCD, so we can decrease cholesterol in the myocytes, that really disrupts the caveoli. And you can see this decrease in capacitance as the caveoli are disrupted. We can increase cholesterol as well if we wish. This manipulation of cholesterol has profound effects on calcium signaling and force within the myometrium. Controlled conditions start to deplete cholesterol, and perhaps surprisingly, you can see this increase in calcium signaling and force. There's the showing of cholesterol, which actually, if we increase cholesterol, it'll decrease calcium and force. So cholesterol decreases force. So what's happening here? Well, the answer, we need to think about EC coupling again, and remembering the effects of outward current due to potassium movement. If we record outward current under controlled conditions and compare that with depletion of cholesterol in the cell, and what you can see is that significant decrease in outward current, which you'd expect to be associated with increased excitability. And if you switch to current clamp mode, what you can see is as we start to deplete cholesterol, increases in excitability, and then a firing of action potentials, which is what is underlying these changes here. So micro domains, microenvironment, in this case, the caveoli, are really important for signaling as part of the EC coupling process. And our data suggests that cholesterol decreases excitability in the myometrium. And hence, if we decrease cholesterol, we increase excitability, and suggesting to us that this could be linked to poor labour outcomes in obese women, because in general, obese pregnant women have high cholesterol levels and poorer labour outcomes. But unfortunately, I haven't got time to go into any of the details that we have that would lend support to that hypothesis. So let's move on to the macro environment and thinking about labour, contractions, and acidity. So thinking of the pregnant myometrium, here it is, this thick muscular tissue that's protected and surrounds the fetus, but is also needed in labour. Very powerful contractions. The uterus is, of course, via the placenta, linked to the fetus. And you can see that within the myometrium, of course, are the blood vessels that feed the placenta and thus the fetus. Very strong contractions in labour, and what they will do is clamp down, they'll occlude those uterine vessels. If seeing is believing, here you go. Phasic contractions in vivo in an anaesthetized rat, simultaneous recordings of blood flow, and it's very clear that the peaks of force are associated with dips in blood flow. In other words, there are repetitive transient hypoxic episodes. That, of course, will stimulate glycolysis and lactic acid production. So that made me ask, if lactate's increasing, presumably that will reduce pH. That's just in vitro measurements. Yes, of course, a weak acid reduces pH. But in vivo, do we get a reduction in pH? And secondly, does the lactate that's increasing during this contraction, does that actually, because it's an acid, reduce contractions? So to answer the first question, we've done simultaneous recordings of contractions and pH in vivo. This time we've measured pH using NMR spectroscopy, and we've divided and analysed the contraction during these phases. So at rest, you can see this measurement of intracellular pH. As force develops and peaks, there's a significant decrease of intracellular pH in the myocytes. So it starts to relax on recovery, and during the equivalent of diastole, restoration of the pH to previous values. So contractions produce hypoxia and also reduce pH in vivo. So can lactate reduce contractions? Can acid reduce contractions? Here's a piece of human myometrium contracting very nicely in vitro, and you can see application of lactate inhibits or even abolishes contractions. If we stimulate this tissue with oxytocin, which is done in labours where contractions are not going well, and then add lactate, you can see that's still a decrease in frequency, decrease in amplitude of contractions. So with or without oxytocin in the physiological range, lactate decreases force, decreases contractility. How's that happening? Well, I've said it's a weak acid. What happens then if we do a pH null? If we add a weak base to counter the acidity of the weak acid, so we null any pH change, in this case by adding ammonium chloride. What will now happen when we add lactate to the myometrial strip? And the answer is very clear. Without the pH change, lactate does not reduce the contractions. In other words, we're not seeing this as a metabolic effect, it's a pH effect. So lactate acidifies and reduces force in the myometrium. But of course, how is it doing that is our next question. How does acidity reduce force? We come back to our EC coupling. Simultaneous measurements of membrane potential and force. And what you can clearly see is a hyperpolarization during acidic conditions. And what that means, of course, is that we inhibit action potentials and therefore calcium contractions and force. So we have a negative feedback mechanism I want to persuade you of during the course of a contraction. So let's go through this. You've seen already that contractions reduce blood flow and produce hypoxia. That will increase lactate, and that in turn reduces pH. The acidification reduces force. As force starts to decrease, so the clamp on the uterine vessels decreases. So blood flow increases, we restore lactate and pH, we have normoxia, and we're ready for the next powerful, good contraction for labour. And this negative feedback is also a protective mechanism. So just think if the contraction went increasing and increasing in strength or duration, think of that clamp on the vessels and the blood going, or in this case, not getting to the fetus. The fetus will become distressed. That's an emergency and a very serious, indeed deadly condition. So within the contraction is a negative feedback loop limiting the likelihood of this happening. So it's a protective cycle. So can we use this knowledge of EC coupling to start translating some of this to help women in labour? And my focus here is on this restorative loop. What if something interrupts that? We need many, many contractions for labour. And what if we don't always get a complete return of these important parameters? So that with a build-up contraction by contraction of acid, for example, the frequency decreases, the amplitude decreases. And this would be a condition recognised clinically as a dysfunctional labour. The contractions are no longer strong enough to dilate the cervix, so it stalls at 4 or 5 centimetres rather than the required 10 centimetres dilation for delivery of the fetal head and then the baby. This occurs in around 10% of women. Some of them will be given the only treatment we have, which is oxytocin. 50% will respond to that. The other 50% do not. And the only way to get the baby out safely is to perform not forceps, but an emergency caesarean section. So this is unplanned surgery on women who are labouring dysfunctionally. And it would be really good if we could do something to decrease its incidence. And the question I asked is acidity involved in dysfunctional labours from the evidence that I've given you so far? So we're into part 3 of the presentation. So working with clinical colleagues, we took blood from the first uterine incision during the caesarean section. Capillary blood flow, blood is collected. Analyse it on the labour ward, blood gas analyzer, and then have 2 consultant obstetricians define what the labour was, including this group here of dysfunctionally labouring women. So these first 3 groups had very similar myometrial capillary blood. However, the women labouring dysfunctionally had significantly more acid myometrial capillary blood. What's more, they also had increased lactates. This is a lactic acidosis around those myometrial cells. And this was the first insight into cause of dysfunctional labour. So could we take that even further? Can we actually now improve labour outcomes, having seen how important pH and acid are in dysfunctional labours? We've seen the in vitro pH null. What about an in vivo one? Ammonium's not very pleasant, not very palatable, but sodium bicarbonate, another weak base, is something we can tolerate. It's a fizzy drink, basically, if you add water to it. So we wanted to know whether bicarbonate can reverse poor contractility in women labouring dysfunctionally. This is basically sodium bicarbonate. It'll be the same in every country where you can get, probably from the corner shop, the chemist, sachets, sodium bicarbonate, sometimes made more palatable, say, with some vitamin C added, but basically you add it to water, you get this palatable fizzy drink. So the small randomized controlled trial was women in their first pregnancy, and they had to have a clinical diagnosis of dysfunctional labour. They were randomised. 100 had the standard treatment, trioxytocin. The others had the sachet of bicarbonate. After an hour, they were given the standard treatment. And our endpoint was to record labour outcomes. What we found was pleasing changes in some of the maternal and fetal parameters, but our endpoint was a glorious result. Look at that reduction in the number of unplanned emergency caesarean sections. Now, in my country and throughout most of the developed world, it's relatively safe and easy to have this operation. That is not the case throughout the world, and it's a cause of maternal death, the unavailability of delivering the baby that is stuck in the birth canal. So imagine if you could actually get the bicarbonate there and give it to these women throughout, for example, sub-Saharan Africa. You don't need an electricity supply for a fridge for bicarbonate, doesn't need it. And you don't need 10 years of clinical training to open a sachet or spoon some bicarbonate into water. So my hope is that this will lead to progress and reduction. Final thoughts before I show you this new way of delivering. There's the uterus, new way of delivery by my granddaughter. Many fundamental questions remain, and I'm sure you'll have many to ask me, and I'm sure I won't know the answer to many of them. It is undoubtedly time to make better progress and to translate results when we have them. And we've got to bring more people into studying this area and infuse the next generation of physiologists. So here's Zoe doing her experiment. That's her sister saying that worked. That's a good mode of delivery. And there we have an enthusiastic future scientist, I hope. I finally just want to thank all my colleagues, students and funders over many years, and to say thank you to the journal and the society. Thank you.